Hi, I'm Richa Thakur. I'm a third year fellow at Northwell Health in Long Island, and I'm really excited to introduce you to Dr. Devine. Dr. Devine, would you mind introducing yourself for our audience?
Sure. First, thank you for having me on this podcast. Yeah, I'm Stephen Devine. I'm an adult medical oncologist, transplant physician, and currently I'm the chief medical officer at NMDP, and also a senior scientific director with the Center for International Blood and Marrow Transplant Research, or CIBMTR for short.
Thank you so much for being here with us. We recently heard you guys had presented an access trial at ASCO, so I'm really excited to hear more about those findings. But before we start, would you mind telling our audience a little bit more about NMDP and some of its mission statements?
Sure, I can tell you maybe about NMDP and the CIBMTR and how they kind of are very much aligned. And so NMDP, it was formerly called the National Marrow Donor Program, which was started as a donor registry. We've changed to NMDP because we do so much more than only recruit donors, which again we'll talk about in a second. But our mission is to save lives through cell therapy, predominantly through blood or marrow transplantation, but we've also been very involved with cellular immunotherapy. You've probably heard about CAR T cells and some other ways of using cells to fight cancers, but now it's even moving into autoimmune diseases. So it's really an exciting time. And so, we're very involved in that space. And you could consider the CIBMTR is sort of the research arm of the NMDP. And the mission of the CIBMTR is to lead transformative and collaborative research that improves outcomes in cell therapy. So very much aligned. And it's the CIBMTR that runs our clinical trials as well as a lot of our observational trials that we do with the community through working committees.
I see. Thank you for explaining the two for us because, to be honest, this is the first time I actually heard that NMDP was also involved with like hematologic cases, especially like autoimmune conditions. It's really nice to see how much like therapy has grown the past few years.
Yes, I mean, there's even, there's uses now in regenerative medicine, cardiac diseases, and so it's expanding. I would say the vast majority of the patients that we interact with now have blood cancers, but certainly blood and marrow transplantation can be used for many pediatric conditions, storage diseases, hemoglobinopathies like sickle cell disease, et cetera. So it's really an exciting time.
That's really fascinating. And I mean, speaking of exciting times, both just recently released results for the Access trial at ASCO this year, and was also selected, I think, as best of ASCO for July of the summer. Right? Would you mind telling us a little bit about the Access trial and what's so significant about it?
Yeah, so I like to talk about it actually. So the fact that it was chosen as a oral abstract presentation at the American Society of Clinical Oncology meeting, or ASCO, was because I think there's really a lot of interest in what we're trying to do with the study. And so just a little bit of background, there are many diseases we were just talking about for which a blood or marrow transplant is actually the best and sometimes the only chance for a cure. And so historically, the best outcomes with blood marrow transplantation has been using a relative, usually a sibling, who actually matches with the potential recipient. But unfortunately, the chances of finding a perfect match within the family is only about 1 in 4, at most 30%. So that's where people typically, if they don't have a match, they come to the NMDP to have them help us find a donor for them. And, we run a registry and provide access to over 41 million donors globally, because we not only have our own registry, but we provide access to all of the global registries. And so we try to find matched donors for patients that way. But the problem that we're trying to solve with the access study is that not everyone has equal access to a matched donor. And that actually runs along the patient's ancestry. So for instance, a non-Hispanic white person like myself has more than an 80% chance of finding a match through the registry, but an African-American Black patient has less than a 30% chance. And then Asian Pacific Islanders or Hispanic, Latino patients, somewhere in the 40 to 50% range of finding a match. So the issue is, how can we try to have a good outcome and find suitable donors for patients who don't have historically what we would call a perfect match in the registry? And that's really the subject of the access study. Can we have good outcomes with less than so-called perfectly matched, but what we would call suitably matched donors? And so the study uses actually a already FDA-approved drug called cyclophosphamide that's given after the transplant to try to prevent graft versus host disease. So it's not using any kind of really fancy therapy. It's an already approved therapy that's used to prevent the major complication of transplant called graft versus host disease, or GVHD. In doing that, we found, at least in the first 70 patients who had leukemia, myelodysplastic syndrome, other types of leukemias, that the outcomes at 1 year after transplant were as good as we would anticipate for patients who had matched transplants. The rate of complications like GVHD were relatively the same, and the overall survival was pretty much the same as we've seen in other studies using matched donors. So that's a really exciting outcome.
That's incredible. I feel like we often struggle so much to get patients a matched donor, and there's always delays trying to find a match, but it's really nice to see so much improvement in that area too. And one thing I really appreciated about this study too was there was a significant number of the patients that were also minorities. I think about half. And usually most of the studies that are published, it's really hard to apply those studies to the patient in front of you because they don't really reflect, the studies don't reflect the patients in your clinic. So that was one thing I really did love about this study as well.
Yeah, just to follow up on that, that I think is one of the remarkable aspects of the access study is the demographics. I mean, typically in transplant trials that require matched donors, about 80%, sometimes 85% of the patients are non-Hispanic white, and you have a very small proportion of the patients enrolled that are more racially or ethnically diverse. So as you said, it's over 50% of the patients enrolled in the access trial were diverse, which is really unheard of in transplant. But it's also, remember, it's also a clinical trial. So one of the issues, when you hear people talk about health equity and access to clinical trials, that they're not necessarily representative of the whole US population. And I think here with the access study, we can say these are truly representative of the US Census, which I think is, again, a unique aspect of the study.
Absolutely. And especially since a lot of the sites that were part of the study were all over the country too. So I really feel like it does do a great job representing our population.
Yes, there were 13 sites across the United States. Again, we report the first 70. Once we got all the sites activated, we've had more than 30 transplant centers, again, representing all the geographical areas of the United States that have enrolled patients onto the ACCESS study.
Do you know what's planned next for this study? Are there plans to increase enrollment or expand it to other sites?
Yeah, so actually the ACCESS study had an adult. There were actually two different strata of adults who could withstand the stronger type of chemotherapy, what we call myeloablative conditioning, and then a group of older adult patients who were in a cohort that received less intensive, or what we call reduced intensity transplants. And then a third stratum that enrolled pediatric recipients. And so the two adult strata are actually closed. We accrued up to 268 adult patients, and I'll tell you why in a second. The pediatric stratum has 20 children and young adults enrolled to date, and that remains open. We'd like to keep that open so that we can get up to maybe 25 to 28 pediatric recipients, which is actually pretty good size for a pediatric trial. And so, as I said, we've finished enrollment on the adult strata, and we should have information available in the next 6 to 12 months on all those patients. The reason we wanted to expand the numbers was because we wanted to look at not only the patients who had 7 of 8 matches, but also had less than 7 of 8 matches. And so we kept it open to that large number of adult recipients. But we're actually already on to the next study, which is called Optimize, which is again looking at using mismatched donors, but trying to make the transplants even safer by reducing the dose of that drug I mentioned before called cyclophosphamide that's used to prevent graft versus host disease. And that trial is already accruing now.
That's so exciting. I'm really glad to hear that this trial also is still accruing a lot of the pediatric populations. I feel like so much pediatric oncology research unfortunately lags a few years behind because we want to make sure it's safe in adults before we would even try a trial in children.
So our prior trials, actually, we did a trial called the 15 MMUD study. It was because it kicked off in 2015 that only enrolled adults. And the reason we felt that we really should learn whether this was also applicable to children. As you said, that's always an unmet need. And we're finding that the patients being enrolled in the pediatric group are really patients who have no other options. They can't even find a mismatched family member. So these are truly patients that have a complete unmet need. And so I think our organization, NMDP, is committed to allowing access to a life-saving therapy for these children as well.
That's so glad to hear. And as you had also said before, it's really important that these patients get access to cellular therapies because that's really the curative backbone for so much of our blood cancer patients. So I'm so glad to hear all of these initiatives. Do you think there's something else that we should discuss with our audience about the ACCESS trial or Optimize or NMDP or CIBMTR as well?
Well, I think that NMDP and the CIBMTR are doing this in collaboration with the entire transplant community. We couldn't do it without the people who are actually in the trenches, as you mentioned, in the clinics, seeing these patients. And, they came to us and said, hey, we have patients that we can't find donors, and they wanted us to work with them. So what I like most about this is really a collaborative network effort where everyone's working together to solve a big problem, right? We couldn't find donors for patients, and we're really, changing what it means to be a suitable donor I think the other thing that we're learning is that many of the donors for these diverse patients are actually diverse themselves, so that the donors often share the same ancestry as the patients. So the other message that we're learning is that we still need to diversify the registry. We won't be able to solve all these issues just with non-Hispanic white donors. So we need to continue to recruit young, diverse donors to the registry, and so that we'll offer all of these potential donors the chance to save a life.
Absolutely. I couldn't even agree more. For anyone out there that's interested in donating, do you have any suggestions on how they could sign up?
Yep, well, just we have a lot of information on our website, our Be Connected website. I think it's nmdp.org. There's a lot of information that we share with people who would want to sign up to be a donor. It's a great thing to be able to do.
So we'll definitely link it in the show notes for everyone. And thank you so much for being here, Dr. Devine. It was so nice to meet you. And I really enjoyed hearing so much more about these institutions and also all of the trials coming out. I can't wait to see the results of the optimized study too.
Great. Well, thank you for the opportunity to discuss the trial. Really appreciate it. Take care.